Welcome, everyone. My name is Chad Severs, and I'm the project coordinator for Arkansas Building Effective Services for Trauma. We're glad that you joined us today for today's webinar, Assessment Use in Trauma-Focused Cognitive Behavioral Therapy. Our presenter today, I'm going to introduce himself a little bit more, is Dr. Benjamin Siegel. He's an assistant professor here at the University of Arkansas for Medical Sciences. And I've had the privilege of knowing Dr. Siegel for a number of years now, and he is now an international trainer in trauma-focused cognitive behavioral therapy. So we're really lucky to have him in our state, and really excited about today's webinar. I'm going to go over a couple of housekeeping items here first, and then I'll turn the rest of the presentation over to Dr. Siegel. If you'd like to ask a question during the presentation, use the question feature, which is on the right side of your screen, and we'll try to answer those as they come up. And if you're interested in earning one continuing education unit, just be sure to stick around to the very end. A code will be given, and you can email that to me, and I'll give some more instructions at the end of the webinar. If you're watching as a group, each person will just need to be able to email me individually. And we are recording this webinar, so if you happen to be watching this at a later date on our YouTube channel, we only give out fees for attending live webinars. And we're pretty new to the social media world, so we do have a Facebook page, and we frequently post about upcoming trainings and webinars such as this one. So be sure to check us out and like us if you want to know more about issues pertaining to child trauma and what's happening in Arkansas. So I'm going to turn it over to Dr. Siegel and let him talk about the webinar.
Well, welcome everyone. Thank you, Chad. Chad, just let me know, can you hear me fine? You were sounding a little robotic when you were talking. I think I caught everything, but just want to make sure that everyone is coming through clearly for me.
And you sound good, and I apologize if I sound robotic. It's probably from the phone system. So.
Okay. Well, as long as I'm coming through clearly. So welcome everyone. Today we're going to talk about ARBEST assessment of trauma and behavioral and emotional difficulties using the measures that we have on our website. Just to let you all know, we do have another webinar available that discusses the nuts and bolts and the how-to of using our website, getting the measures, entering the measures onto our website, and the scoring from that website. This webinar is going to focus more on using the assessment measures clinically, integrating it into TF-CBT, and also helping to determine if TF-CBT is appropriate or not, and also some tips and strategies to get the most information out of using these assessment measures. I'm just trying to change the page. Okay. So the ARBEST assessment tools. We have two of them that are available on our website. The UCLA PTSD Reaction Index and the Strengths and Difficulties Questionnaire. I will refer to the UCLA PTSD Index as the UCLA and the SDQ, or Strengths and Difficulties Questionnaire, just the SDQ, just to make it a little easier to follow. The UCLA is a measure that assesses for trauma histories or trauma exposure for children and adolescents, and gives current PTSD symptoms related to that traumatic event or traumatic exposure. The Strengths and Difficulties Questionnaire is a measure of behavioral and emotional assessment of children and youth to give you a sense of general behavioral functioning, so disruptive behavior, oppositional defiance, inattention, hyperactivity, anxiety, depression, and there's also a measure of pro-social or positive social emotional skills on the Strengths and Difficulties Questionnaire. They're both relatively brief to complete, taking somewhere between 5 and 15 minutes. So first to talk about the UCLA, and the UCLA is going to be most pertinent to your TF-CBT work. This is a measure of trauma symptoms. This is also where you're going to get your most useful information to help you decide if TF-CBT is appropriate, and the information from this you'll then incorporate into your TF-CBT treatment. So we are using the DSM-4 version of the UCLA. The DSM-5 version has come out, but it's not really at the point where we're comfortable with it yet. So we are using the DSM-4 version. So just a reminder, DSM-4 has 3 symptom scales for PTSD: intrusion, avoidance, and arousal. So intrusion are things like nightmares, intrusive thoughts or memories. So a child is walking to school and passing by the intersection where the car accident happened that killed their father. A flood of memories is popping into their head. It's like they're reliving it again. Avoidance symptoms. These are symptoms like not wanting to talk about the events, avoiding places or people that remind them of the traumatic events. Within avoidance is also that emotional numbing or flattening, loss of interest, loss of pleasure, some sort of depression symptoms. And then arousal are the sort of hyperarousal symptoms like overall irritability, concentration difficulties, high arousal, exaggerated startle response, some of those symptoms. So the UCLA will give you scales within those 3 symptom scales, but also an overall traumatic stress symptom scale. And so we'll be looking at that as one piece of the puzzle of helping us to decide if a kiddo has PTSD symptoms and whether or not TF-CBT would be the most appropriate treatment. So the UCLA has a child report, an adolescent, and a caregiver report, meaning that you could have a child under 12 report their own symptoms. So what events that have happened to them or they experience, potential traumatic events, and their current PTSD symptoms, an adolescent report. So those kids 12 and up, where they're asked the same questions, but it's the adolescent report, or a caregiver report that will cover both the child and adolescent age range. So the caregiver is reporting about the child or adolescent's traumatic event experiences and their PTSD symptoms. I recommend if giving both, if at all possible, so having the child report it and the caregiver, or the adolescent and the caregiver, just to give you as much information as possible. So that's just a little bit of an overview of the UCLA. A couple reasons why we want you to do a UCLA. First, about the traumatic event history. So we're going to go over the specific pieces of the UCLA in a second with screenshots, but the beginning part of the UCLA is a traumatic event screener, where it asks about certain difficult, scary events that may or may not happen to that child. And it asks yes or no if that has happened. It's important to ask about these specific events because it may not be reported during the intake. It gives you a list of potential events that the caregivers may not have thought of. Could be potentially traumatic, certainly domestic violence or medical injury could be traumatic. It sort of prompts their memory that, oh, this might be something we need to ask further questions about. It helps the clinician make sure that we're not missing any potential events. One of the reasons why we do the child and adolescent filling it out and the caregiver, that oftentimes we see the caregiver knows that a potential event has happened but thinks the child may not remember it or has forgotten that this happened, and the child may mention this in their completion of the UCLA, and there might be symptoms related to that. Because there is that myth and misperception that a young child won't remember traumatic events. A lot of times kids will remember traumatic events. Unfortunately, we've had a lot of cases that have come to our clinic where caregivers have gotten that advice that you shouldn't talk about the traumatic events, the child will forget it, they'll get over it. And so when we do the UCLA, we ask the caregiver, well, yes, for instance, sexual abuse happened, but the child was young, we've never talked about it, I don't think the child remembers. And then we'll give the measure to the child, and the child will not only remember it, but be having active PTSD symptoms related to it. So it's important to ask these questions to see if the child remembers or if there are events that have occurred that weren't previously reported. And then oftentimes, a child will report something that the caregiver didn't know is happening, maybe bullying at school. That can certainly be traumatic, but the child may not have told the caregiver yet. So it's important to ask those questions. And then the rest of the measure is really getting about trauma-specific symptoms. Why do we do this? First, we can't decide whether or not we're going to do a trauma-focused treatment like TF-CBT unless we know the child has trauma symptoms. And by asking about symptoms and asking about events, we're gathering a lot of good observation. We want to know when we're talking just a little bit about these difficult events, let's say physical abuse. When the child is responding to these questions, are they becoming hyper-aroused or fidgety in their seat or getting really nervous? Or are they putting forth a lot of energy to avoid talking about it? Those are all good clinical observations to help you decide that this child is having difficulty talking about these things and can't talk about these things. And when they're brought up, the child may be having some intrusive thoughts and memories. Also, some kids we know and adults that have gone through traumatic events, and actually the majority of kids and adults that have gone through traumatic events don't go on to have PTSD symptoms. So roughly 2/3 up to 3/4 of, generally speaking, of folks that have been through traumatic events don't go on to have PTSD symptoms. There is a subset, roughly 1/4 to 1/3 that do go on to have PTSD symptoms, and those are definitely the kids we need to do a treatment like TF-CBT with. But given there's a large population of kids and adults that may have had traumatic events and not having symptoms, doing these measures and assessing for their reactions and watching them talk about it, maybe it's not their favorite thing to talk about, but when prompted to, they can give some details and talk about their thoughts and feelings related to it, but they're not having those hyperarousal symptoms or those avoidance or seeing some of those physical symptoms in them. That might show you that this child, another observation or another piece of the puzzle that says, okay, maybe this child isn't having trauma symptoms and their difficulties might be related to something else. It's also important for TF-CBT with gradual exposure. One of the things that we promote within TF-CBT and trauma work is that a classic symptom of trauma is avoidance, and that avoidance leads to PTSD symptoms. It leads to those thoughts and feelings seeping out into everyday life, and one of the ways to tackle that avoidance and symptoms is slowly, under safe situations with coping skills, allow the child to remember, think about, talk about the events, the traumatic events, and with that, trauma symptoms reduce. And so by directly talking about the traumatic events and a little bit about their symptoms, we're starting that gradual exposure process. The assessment process is part of TF-CBT, and by doing this, we're starting that gradual exposure. Certainly, by directly talking about trauma, we're practicing not avoiding. We're going to use correct language. We're going to directly ask about events that have happened and their symptomology, current symptomology related to it. It is important, because a lot of kids are resilient or don't go on to have PTSD symptoms, it's important to do these measures to give the caregiver or the child some reassurance that they're doing well, they're not having trauma symptoms, that they have healthy coping skills and they have a healthy support system that has gone a long way in alleviating trauma symptoms or guarding against sort of creation of those trauma symptoms. So this is a screenshot of the UCLA. So this is the first page. This is the part that I talked about where it asks, has something very scary, dangerous, or violent ever happened? And then it goes through a list of questions and asks yes or no. So been in an earthquake, yes or no. Been in a bad accident, like a car accident, yes or no. And then there's 13 questions that ask about specific events. And then it gets to question 13. Question 13 is very important. Question 13 asks, are there any other situations than the ones that are previously mentioned that have ever happened to you that were scary, dangerous, or violent? The UCLA is a great measure, but it does not have a list of every potential traumatic event. And so this other question is very important, that this is the catch-all. So for instance, I see a lot of kids that are in child welfare custody. The UCLA does not specifically ask about, have you ever been removed from your biological parent's household? Have you ever been in foster care? That can be a traumatic event. And if we don't ask this question or follow up with something from the interview, we may miss that. And then I'll get to question 14 in a second. So what I typically do on these is I will go through the yes or no questions in order up to 14. I will not follow up until after I get through all of them. So I will go natural disaster. Nope, never been in that. Has anyone touched your private sexual body parts when you did not want them to? Yes. I'll go on to the next one. No. And then after I go through 13, then I'll go back and ask more information. Just a little bit more detail. So you said that someone had touched your sexual private parts when you did not want them to. Tell me a little bit about what happened. Just to get a little bit more information, then go on to the next one. Well, you said you were in a natural disaster. What kind of natural disaster? Well, I was in a tornado. You know, was there any damage to the buildings you're in? Well, no, but it passed by, and you know, my aunt's house was destroyed. The reason I wait to go back for details is if a child is very avoidant and you ask follow-up questions, they're going to quickly learn that if I say yes, I'm going to get more questions about it. And I don't want more questions about it. So I'm just going to say no for the rest. So we get better information and accurate potential information by going through the questions in order, then following up. So with question 13 also, if there's something that's been reported by the caregiver or within the intake that you know, oh, for instance, the child's been in foster care, but the child doesn't mention anything else, you can say, oh, you know, we talked about earlier that you were in foster care after your mom overdosed on drugs. Was that scary? Oh, yes. So, oh, we'll mark yes for that one. So that's how I typically go through 1 through 13. Question 14 is also very important. And this is where you really have to understand the UCLA to get the most and best use out of it. So question 14 asks, of the previous 13 questions, you may have checked one or more, which of those items bothers you the most now? And you pick one. And whichever one you pick, the child then answers those questions, answers the rest of the questions related to that event. So that's very important to know. So let's say this child said, sexual abuse is the one that bothers me the most now. The rest of the questions that get at PTSD symptoms are related to that sexual abuse. A lot of times, everything is lumped together, and kids can't differentiate. That going into foster care because of mom's OD and death led to you know, separation loss, a lot of rehoming, physical abuse or bullying while in foster care. And it's all lumped together. It's okay for the child to say, I can't differentiate, that's all been bad, or these events. The child can answer the rest of the questions for that. Just make a note of it. I will often start with the one that the child says is most impactful. So let's say we have a child that says, oh, there was a tornado and I was sexually abused. The child says, the tornado bothers me most. I will then go with that and answer the rest of the questions for the tornado. Then I will go back and I will do the same thing for the sexual abuse. So I would just administer the rest of the questions for sexual abuse so I can have scores for each to help me determine where do we need to take the focus of TF-CBT. So also within question 14, there's a little bit of a test narrative, and this is good for observation. So once the child says which one's the most bothersome now, it asks a couple questions about what happened. And this is where you're going to get, again, those observations about, you know, how easy are they able to talk about it? Are they uncomfortable? Are they completely avoiding it? Are they becoming fidgety? Are they looking like they're about to dissociate? Do they suddenly have to go to the bathroom or get a drink? All of those are good for observation. So that's an important piece of it that really we want to make sure we fill out. So after we go through this, it transitions to the next part. Now remember, the next part of the UCLA, this is the second part, it asks about when the bad thing happened. Oh, whoops, I skipped question 2 on this. I apologize. But the middle part, the section, it's pretty straightforward. It asks about at the time the event happened, so the sexual abuse. What were your feelings at the time? Were you worried you were going to die, or worried someone else was going to die? It's just yes or no. People usually don't make mistakes on that. It's fairly straightforward. Then it comes to the third part. So this is the part where the child or adolescent or adult is responding to current symptoms within the past month related to question 14. So if they chose sexual abuse, they are answering these questions for sexual abuse. So for instance, question 1, I watch out for danger or things that I'm afraid of. That one doesn't mention the sexual abuse, but that's just in general. Question 2, when something reminds me of what happened, sexual abuse, I get very upset, afraid, or sad. And then they're answering how often that happens within the last month. And again, it goes through a series of questions, and all of those are to get at the overall traumatic stress score and the 3 symptom scale scores. So the intrusion, the avoidance, the arousal. That's where those scores come from. Now, this is from the ARBEST website. So when you enter and finish a UCLA, the ARBEST website will give you this graph that pops up. And this is the overall, if you can see my mouse, the overall child's total stress score. So this blue square. And for this is a report, and the total score is 36. And baseline is assessment the first time that you administer the UCLA. For this kiddo, a score of, 36. Oops, sorry, skipped ahead, don't click. 36 is within the moderate distress level. So these are 27 is mild, 33 is moderate, and then 38 or above is significant. So moderate distress is sort of like the at-risk. There are symptoms of traumatic stress. They're not off the chart, but with a score like that and other observations and your diagnostic interview or intake, if you're fairly certain there are a lot of PTSD symptoms, you're going to proceed with TF-CBT. Same thing with kids in the mild range and your clinical observation and so forth. A score of 38 or higher there's a 95% likelihood that that kiddo meets criteria for PTSD. So if you have a high score, higher than 38, there's a strong chance we're seeing PTSD symptoms. Now, I'm going to go back to what happens if, sort of common question. Well, in the intake, in my observation, this kiddo sure seems like they're having a lot of PTSD symptoms, but they're scoring a 12. What does that mean? I'm going to come back to that. But I just want to go through this graph and the next graph. So then this is the breakdown of the scale scores. So arousal, avoidance, and intrusion. So it breaks that total stress score of 36 was the total score for this child into those different categories. So for this child, arousal and avoidance were the highest ones with less intrusion. So that means that this child is spending a lot of time not wanting to talk about the event, not seeing people, places, things that remind them of events, and having a lot of hyperarousal symptoms. So difficulty sitting still, exaggerated startle, difficulty concentrating, but not necessarily intrusive thoughts. Kids can look very different. And then over the course of treatment, I'm going to go back for a second. So these are the follow-ups. So this is when the clinician, and the clinician can do this as many times as they want, followed up with the measures, you see that their overall score is going down over time. So maybe, this is assessment, the first one. The second one would be, a month or two in, and we're learning prac skills and coping skills. A little improvement maybe. And then maybe 29 would be right before the trauma narrative. So we've seen symptoms going down, but not as much as we'd like them to. But if we break them down, follow-up 1, this would be learning these coping skills. We've noticed arousal's going down a little bit, avoidance gone down, but intrusion's gone up a little bit. Interesting, right? Why would the arousal and avoidance go down, but intrusion going up? Typically, I'd ask you the questions, but you're all on mute, so I'd get no answers. One of the reasons that we typically see with TF-CBT is when kids or adolescents are highly avoidant, they'll avoid those thoughts and feelings and putting a lot of energy to it. We're doing gradual exposure, so we're slowly having them talk about those events more. And with that gradual exposure, that might mean that they might have a little bit more intrusive memories or thoughts. Certainly not anywhere near overwhelming. We're monitoring. That's why we're doing these assessments. And what then you see the next time is, arousal has gone down, intrusion's gone down a little bit, but avoidance has gone up. What we could now be seeing is the arousal has gone down and the intrusion's kind of, gone down a little bit. Now maybe it might be a healthy avoidance. Sort of it might be more of a defense mechanism that, okay, I've talked about it, I've processed, I've learned my coping skills, my arousal has gone down, I'm not having really intrusive thoughts, the score of 6 is still pretty low. But I still don't want to talk about it. Maybe this was before the trauma narrative. We do the trauma narrative, a little bit more avoidance, tackle more avoidance, gradual exposure, reducing that arousal and intrusion, and we would hope to see those scores fall down further. So just an example of how you could interpret these symptoms and scores over time. And then the last, oops, I pressed that too many times. The last report or last graph that you'll get from the UCLA is the individual scores from the items on that third part. So the first cluster is intrusion, the middle is avoidance, and the last is arousal. So within intrusion, the questions are intrusive recollections, recurring dreams, flashbacks, psychological reactivity. And remember, intrusion was a little bit lower for this kiddo. So twice per month recurring dreams, 1 to 2 times weekly physiological reactivity, or intrusive recollections. Kiddos having high avoidance symptoms, trouble remembering, detachment, restricted affect. These are more depressive symptoms when you look at them. But sort of the classic PTSD symptoms, avoiding thoughts and feelings, avoiding reminders, those aren't as high. So what we could be seeing in this kiddo is maybe this kiddo is reducing trauma symptoms, but we're still having some depression symptoms. And then arousal is the last one. So the sleep problems, concentration difficulties, hypervigilance, startle response, being on edge. So a 4 is almost daily. So this helps gather more information about your kiddo and what symptoms the child's having related to PTSD, and also gives you information when you proceed with TF-CBT to help you use this in psychoeducation. We're going to talk about that a little bit later. So going over the SDQ, strengths and difficulties, really quickly, because this is much more straightforward than the PTSD index. Adolescent caregiver reports, 25 items. There's 5 scales: emotional, behavioral, attentional, peer relations. So peer relations are those sort of aggression with peers, getting along with peers, more of those difficult peer relations. And then pro-social behaviors are positive behaviors, good social emotional skills. So there's 5 questions within each scale for a total of 25. This is just a screenshot of the strengths and difficulties. All of the questions are the same format. So just in general, how true are these statements? How true or is my child is considerate of other people's feelings? Somewhat true. My child is restless, overactive, can't sit still for long. Not true. And then goes through the rest of the 23 questions. Pretty straightforward. There is not a child report for this. So for the SDQ, the adolescent, so kids 12 and up, can complete it on their own, or there's a caregiver report that reports on the whole age range, or for those younger kids, so under 12. So this is the SDQ graph. So initial score 28, and if you look, the cutoff is 13. So that means that this child is having a lot of negative symptoms of emotional, behavioral, poor peer relationships. And then at follow-up, there's been a dramatic decline in those negative behaviors. So below 13. And when it's below the cutoff, that means pretty average when compared to normal population. So child's doing well. So this is the breakdown of the scales. So there are 4 sort of negative scales, or things that we want to see improve. Attention, behavioral, emotional, peer problems. Those are the level of difficulties. And then pro-social is a positive one. So pro-social is the amount of good behaviors. And so what we hope to see is pro-social goes up, this asterisk or star, and negative behaviors go down. So for this kiddo, the highest at intake was 9, which was a red square, behavioral difficulties. And behavioral difficulties improved to a 3. Wonderful. And then, attentional difficulties went from an 8 to a 4, and so forth. We also noticed that when we look at pro-social behaviors, be positive, they went from 4 to 6, so an improvement in those pro-social behaviors. The reason why we have a measure of other emotional functioning, so behavioral emotional functioning, is that we know that PTSD symptoms can look like a lot of things. So there's a lot of overlap with trauma and other disorders like ADHD, depression, anxiety, bipolar disorder, reactive attachment disorder, and so forth. I think us TF-CBT providers like myself, I'm a little bit more biased to having a trauma-informed lens and thinking trauma first. If there's a trauma history and trauma symptoms, I'm going to treat that first and foremost. And with the idea that it's going to clear the picture. Once trauma symptoms have been tackled and reduced, then I look at what's left. Are there still ADHD symptoms? Are there still depressive symptoms? Or by treating trauma, have we just seen a dramatic decrease in all those symptoms, and trauma was the root cause or driving the train of those symptoms? So it's helpful to sort of help to differentiate between what else needs to happen after trauma treatment. Because it's perfectly likely that a child could have PTSD symptoms and ADHD. When we treat trauma, and the child truly does have ADHD, they're still going to have ADHD after trauma treatment. But I feel much better knowing that if there are trauma and trauma symptoms, I can treat that well, I can reduce those symptoms, and before prescribing a stimulant or doing treatment for ADHD, I know I can clear that up. And there is likelihood with trauma that we could see some decrease in those attentional, hyperactive, impulsive symptoms. And I would hate to have a child start a medication when it really is trauma symptoms. So some common questions that come up with assessment measures. Parent and child report differ. So my general advice to you all is put the weight in different, sorry, let me rephrase that. In general, caregivers or parents or aunts, uncles, whoever, that significant caregiver adult in their life, are better reporters of symptoms of children. So children 11 and under. Just because of developmental level, we know that if you've got a caregiver report and the child report, we're going to put more weight into the caregiver report, particularly for behavioral symptoms and ADHD symptoms. There are some kids, 9, 10, 11-year-olds, that are better reporter for those internalizing symptoms, those anxiety and depression, because caregivers, teachers, and others, they see the externalizing disruptive behavior symptoms. Those are easy to see. Oftentimes, those depression, anxiety symptoms aren't seen as much, so kids can be missed. And so in general, we're going to put more weight into caregiver report with the caveat that we need to be very careful about those anxiety, depression symptoms, particularly in those like 8, 9, 10-year-old, 11-year-old. Once you get to 12 and up, in general, of course there's some overlap, the adolescent is a better report of symptoms. So if you're going to put the weight in, if you've got an adolescent, you put it on the adolescent report, if you have to choose one. I like to use both, so that's why we give both. But if they're completely differing, and you've got an adolescent, a 15, 16-year-old, I'm going to put more weight in the child report or the adolescent report. If you've got a 6-year-old, and the 6-year-old is reporting no symptoms, and the caregiver is reporting off the chart PTSD symptoms, we're going to go with the caregiver report. When you've got those 11, 12-year-olds, it's a little different. You just got to put a little weight in both, and you really depends on the makeup and the characteristics of the kids and the adults. Why do we see differing reports? Why do we see coming in, doing your assessment, your interview, caregivers giving a lot of trauma-specific symptoms, and then you give your UCLA to an 11-year-old or even an adolescent, 13-year-old, and they don't score any symptoms on PTSD. But when you complete the measure, you notice that they're really having difficulty answering these questions. They're fidgety, they want to stop, they're ready to leave your office. That's giving you some information that they're reporting that they're not having symptoms, because kids are pretty smart. If they report they have symptoms, you might have to address them. That's where you use your caregiver report and your observations to say, okay, they may have scored low, but I'm not quite there to the PTSD level because of the child report, but I'm not going a completely different direction. And so that's where you may start doing your psychoeducation and your practice skills and get more information and feel confident later that they have PTSD and you're going to do full TF-CBT. Or you might provide some psychoeducation and some coping skills, and the kid really is resilient. You know, maybe then you don't need to do full TF-CBT. But what I would tell you in most of those situations where there seems to be something, it's not going to, and you do a good job of assessment and interviewing, and you can make a case that there's certainly some adjustment, trauma symptoms. You know, doing TF-CBT is not going to do harm. It's more of those cases where there really just aren't trauma symptoms. You know, they may be saying some difficulty, they don't want to talk about it, but they can if they want. We don't need to do TF-CBT. You know, they're not having adjustment, they're not having trauma symptoms. But those kids that are sort of in the middle ground, it certainly can't hurt starting with some good psychoeducation about trauma and behavior management and, you know, relaxation, emotional regulation skills, and so forth. Yes, and you know, keep in mind that a lot of kids are resilient. That don't judge or base the decision to do TF-CBT or not solely on their trauma history. Kids can have horrendous trauma histories and not have trauma symptoms. Of course, the more trauma they have, the more likelihood that they're going to have trauma symptoms. But just because a child has been sexually abused or physically abused or witnessed domestic violence, that is not enough to do TF-CBT. So there have to be trauma symptoms along with it. And if there aren't, great. I mean, the kid does not need trauma treatment. There may be other difficulties. There may be depression, there may be ADHD, but the focus doesn't need to be in trauma. And that's good. And so what I want to tell you, first, what's probably most important is that the UCLA, the SDQ are only one piece. That they add to the picture, but they're not the sole thing that you're going to make your decisions on. The scores are helpful. They show you what symptoms they're reporting, but if the score is high or low, that is not the only decision that you're going to make on whether you do TF-CBT. So clinical judgment, you're all good clinicians. You know your stuff. You know your TF-CBT. You can use that along with these results to make that case. So once we've gone over the assessments, we're fairly certain we've got trauma symptoms, we're going to proceed with TF-CBT. How do you use this? Assessment is part of TF-CBT. We've talked about the gradual exposure, but the assessments don't just sit there and you only use them to figure out if you're going to do TF-CBT or not. I share the assessment results with the family. I go over them. I use them as part of psychoeducation. So in psychoeducation, I'm talking about what TF-CBT is. I'm talking what general trauma symptoms are. I'm giving some psychoeducation about general trauma, about their specific trauma, like natural disaster or sexual abuse. And I'm bringing in the assessment results and say, we talked about in our intake, you mentioned that you're having a lot of nightmares related to the tornado and you don't feel safe at night and you're constantly looking at the weather. These are trauma symptoms. So you're making your case for why we're doing TF-CBT. Going through that last graph that says you're having high nightmares. Those nightmares are about the sexual abuse or domestic violence. Those are PTSD symptoms. That's why we're doing this treatment that works for exactly those symptoms. Look here, behavioral difficulties, difficulty concentrating, that's part of trauma. if we can reduce those arousal, we may see some improvements in behavior problems as well. And so it's using these assessment results to make the case for why we're doing TF-CBT. It helps show the caregiver and the child that you were listening, and that they spent the time doing this measure and being honest, that you're looking at it and you're going over with them. And it's hard for a caregiver to argue with their own report. You're saying here, you have trauma symptoms, that's why we're doing this treatment. You're also using the results, so from your intake and your assessment, specifically on the UCLA, they mentioned when they go to sleep at night, they're feeling unsafe and worrying that the break into their house is going to happen again. And they're checking the locks and they can't go to sleep and they wake up tired. That comes out in the assessment. I'm going to use that when I go to relaxation. That you mentioned in the intake and assessment that you're feeling unsafe when you go to bed. We're going to practice relaxation skills. We're going to use some coping thoughts. We're going to have a bedtime ritual to help feel more safe. That's gradual exposure. That's using the assessment results into your components. That's how you do TF-CBT, and not just make it about learning, relaxation and affective modulation, great skills, but that's the gradual exposure piece. You're taking what you know about the kiddo and you're applying these skills to their triggers and trauma reminders. Also, it helps monitor your client's progress. We talked about before and afterwards. I certainly give the UCLA at the beginning and when I'm thinking about discharging to make sure I don't miss anything, to make sure trauma symptoms have been reduced, and also to help out with, when I'm done with treatment, do there need to be any other services? Do we need to target the depression still? Do we need to target the behavioral, disruptive behavior symptoms that are still there despite our best efforts in behavior management and TF-CBT or ADHD symptoms? But again, I'm showing those measures to the caregivers and kids, because if those scores are going down, it feels good. It's a success. I will incorporate them into graduation. Also, if scores are not getting better, reassessing what's not improving. So for some kids, they're so avoidant that they really are emotionally numb or flat. I'm sure you all have those kids or will have those kids. Those are hard kids. They look very depressed and they have trauma symptoms. And in order for TF-CBT to be effective, we need to have them feel some emotion and affect to reduce that arousal and help sort of activate those memories to make sense of them, to reduce that arousal, which will also hopefully help improve some of those depressive symptoms. But if you're not able to tap into that affect or emotion because of the trauma symptoms or avoidance, you're not going to see symptom reduction because you haven't activated that arousal system to bring down that arousal to effectively process it. So it's another thing that if you see like you're kind of banging your head against the wall, give the assessment measure to see what's happening. I think we've discussed most of this. Okay, we have about 10 minutes left, so I'm going to open it up to questions, and type in your question on the side, and Chad will send them to me if you have given questions throughout the call, or I will answer them as we go.
All right, thanks, Ben. Do I sound like a robot still?
Nope, you sound much better.
Okay. Yeah, we've got a couple of questions in, and the first one is, what if the child is not able to read? If the therapist were to read the UCLA or SDQ to the child, would it still be accurate?
Oh, that's a wonderful question. Thank you for asking that. So how do I administer it? I didn't even talk about that. So I love our website. Our website is wonderful. I do not administer the UCLA through the ARBEST website. I always do it in paper. And typically, I will go over the measure with the child. So let's say I have a child in my office. I'll give them a choice. We're going to go over this together. Would you like me to read the questions and you answer? Would you like to read and answer, or so forth? But I do like to monitor when they go through it. If you've got an adolescent, I might let them do it on their own, but I'm certainly going back and looking at it. If you've got a caregiver that can't read, or a child is just not at that level, absolutely you can ask the questions to them. And the thing, I like having the paper copy because it helps me in the moment to look through what they endorse and go back to. It's less easy to do when you enter it on the website. Certainly then you enter it and you get your score, but I like to go through it with them. Even with caregivers, I think ideally doing it in your office with them. But I have given the form to the caregivers to complete in the waiting room while I'm meeting with the child or something like that. But going very specifically over the UCLA and pointing out the parts that are difficult. So I will underline in the first part, these are the events that you're answering yes or no to. I will circle the other. If anything else has happened, mention that. I will circle this question here asks, of the event or events that happened, tell me a little bit about it. And whichever one you pick, you're going to answer the rest for. And then on the last page, I will circle the in the last month and say related to the event that they acknowledge or endorse in question 14. But I do like to go over it with them in my office if they have questions, or with them if possible.
Okay. We're getting a lot of questions in, so if we're not able to answer your question here on the webinar, I will certainly pass this on to Dr. Siegel, and we'll get back to you. Let's see. Okay, our next question is, what is the cost for using the UCLA assessment tool?
It is free. Hooray us. No, because you're part of the ARBEST program and you're involved in training, we've got permission to have it on our website and score it. So there is no cost. Easy question. And the SDQ as well, too.
And that leads into another one. You mentioned a little bit about doing follow-ups. When should you do a follow-up? Can you talk a little bit more about that? I think that's what that question was asking, if you do them both at the same time intervals, or when should you do follow-ups for the SDQ and UCLA?
I will tell you, our website recommends 3 months. But I will also tell you, do it when you think it is most helpful for your case. We want these measures to first and foremost be as helpful to you as possible. So what I typically do is I will give them at the beginning and towards the end of treatment. I think the other place that I think is common to give is right where you're sort of wrapping up the prac skills and thinking about moving on to the trauma narrative, just to get a sense of where the kids are. But that's certainly not necessary. So beginning and end are probably the most common.
Okay. And then this will probably, I think, be our last question here. And so Dr. Siegel, I don't know if you've ever worked with special needs kids who maybe can't communicate verbally, but they are affected. It's just difficult to get that information. So any thoughts or suggestions or resources to help folks who maybe work with special needs populations or kids and families?
Yes, well, that's a little bit of a tough question to answer because it depends on a lot of factors. So there are, for younger kids with special needs that just developmentally they don't have language, their traumas may be more acted out in behaviors. Maybe we're talking about a child with pretty significant autism. In a younger kid, a treatment like child-parent psychotherapy might be more appropriate. TF-CBT takes a lot of interaction between the therapist and the child and the caregiver. and we can try our best to adapt it with, an interpreter, or if there are, ways, to work through a translator or something like that, if it's more than that. I can tell you that in general for special needs, as long as kids are at the developmental level of 3 or higher, TF-CBT can work. There might need to be some modifications. Things maybe need to be more concrete or require more role plays and practice, but as long as the kid's at sort of developmental age 3 and has language of a 3-year-old, we can make it work. I hope that helps.
Okay. Yes, and
that's one I would be happy to answer a follow-up question if just telling me a little bit more about the specific types of special needs.
Okay, thank you. I know we're kind of getting to the top of the hour, so in interest of time, I'm going to, folks who are interested in getting a CU, the code is displayed there on the screen. Just remember to send me an email, and it's really helpful if you tell me your first and last name. It's just easier for me to look up, who attended the webinar. And if you're watching in a group, each person will need to email me individually. And if you can let me know who was the person in your office or group that signed in to the webinar, that is also helpful. So thank you, everyone, for coming out to today's webinar. And I'll leave this code up here for 30 seconds or so, and then we'll have to sign off. And I will pass along those questions we didn't get to Dr. Siegel, and hopefully we'll be able to answer those the best we can. So thank you.
Thank you, everyone.